Dr. Deanna Hagge. I work at Anandaban Hospital in Kathmandu, Nepal with the Leprosy Mission.
Okay, fantastic. Deanna, you've made a very long journey from the mountains of Nepal to come here to very kindly give an excellent presentation this morning at ISNTD Coinfections and Comorbidities, really to do with the co-infection, co-endemicity of helminth infections with leprosy. Now, for many people, I guess we're all guilty of it, it's been a case of working within silos for the last decades. What's your view on that, given that you're looking at two distinct disease settings, leprosy and STH?
It has been a challenge to try and discuss or bring about the idea that these two diseases may interact with one another, in that many people have studied just one or the other. However, looking at leprosy, if you take the maps where leprosy is endemic and where soil-transmitted helminths are endemic and place them on top of one another, 94% of all new annual cases in leprosy come from places that are co-endemic for soil-transmitted helminths. And the other 6% of patients are primarily immigrants from those areas.
You mentioned before that working within silos or working on your own topic for a while leads us to only look at the alphabet in terms of letters. Have we now evolved, and I'm going to use your presentation actually to illustrate this, to a place where we need a lingua franca, a common language between working groups, different settings, different disciplines?
I think that is where science is now graduating to. We have studied diseases in isolation now for several generations, and we're coming to a place where we can combine the letters that we're learning more into words. And these better exemplify the actual context in which these diseases occur. In our laboratories, we do the experiments in isolation, in a perfect setting, but our patients do not live in perfect settings, and they actually live in settings that have many other diseases and challenges within them. And so we are now getting into a place in science where we can actually investigate within that milieu of factors.
It's very interesting. Building on this metaphor of a lingua franca or alphabet to language, do you think it's going to take, what role has the immunological landscape, or understanding the immunological landscape of co-infected patients, what part has that got to play in development of a common language between silos?
Well, particularly soil-transmitted helminths are known now, because of different disease research, to suppress immunity. And that is playing a role in those countries in interaction with many diseases. The diseases that are being most commonly reported right now are those that actually have to interface with the immune system to establish a chronic infection. So therefore TB, malaria, HIV, and even conditions such as allergy are things that we've been able to look at and say, wait a minute, there's some similarities in the way that helminths are impacting the immunology of co-infection, and those correlate to pathways that leprosy also dominates in. So we were able to take that and put it together and come up with our hypotheses.
Okay. Well, you made a fascinating point earlier, staying on this immunological landscape in terms of the Th1 cell-mediated inflammation response in leprosy versus the graduation to a Th2 antibody-mediated response. And on that spectrum, the effect of deworming the patient on those two outcomes in terms of the two reactions. Could you just, I think that's a profound point, because that's something that would touch on the host. It's a profound point for different disease settings. Could you just elaborate a little bit about that for the viewers?
Yes.
Yeah.
So in leprosy, the disease can actually be or present across a spectrum of immunology. So instead of like other diseases where everyone's body responds in the same way, some leprosy patients respond with a polar cellular immune response, and they're able to control better the bacterial growth, but it still develops into disease. However, for some reason we don't understand, other patients develop an antibody response, which is basically ineffective against controlling growth of the bacteria, and they get more diffuse or spread infiltration of the bacteria. And we've seen that amongst patients for what we've known of the disease. We've also noticed that there are patients who can develop symptoms that would be between the poles and can shift at any point in time before treatment, during treatment, or even years after treatment in response to residual particles that can stay in the system. And we've not understood why the patients in between the two poles sometimes are so very unstable or shift. But when we were looking at some of the co-infection papers that were coming out in the last 15 years or so, I noted that it said that there was immunosuppression. And because I live in an endemic country and I see mass drug administration programs, and I see the doctors giving out dewormer, and I'm an immunologist, so I wondered if the suppression of the immune system has been happening for a very long time. What happens when they give them a dewormer and they also have a chronic background disease that's long-term? And by definition, the raising of the immune system back to normal levels would fit the definition of a leprosy reaction, which actually leprosy reactions are the #1 factor for causing disability in leprosy patients.
I think it's a fascinating another level of nuance to add to the MDA, the remodeling, if you like, that's needed in MDAs. That's an absolutely fascinating touch point in terms of presentation. I think it has a lot of resonance with a lot of people working here. We've talked of silos, we've talked of a common language that is needed, and maybe perhaps that common language might take the form of an immune host pathogen immune framework from which we can then relate all these diseases to. Really all about progress through partnership. We've seen quite a diverse range of people all working in a co-infected or comorbidity type of setting, whether that's through communication with the NTV thing, or whether that's through biology or pharmacology or diagnostics, even economics we've covered. The question is, what type of partnerships would you like to form to further your work?
Well, understanding that helminths are operating in concert to probably help leprosy thrive in these endemic populations, and then also setting them up for probably worse outcomes. I think people involved in leprosy would be very interested in the same things for elimination of those worms. That if the worms and leprosy are working in partnership to persist in these endemic populations, then the very same things to eliminate the worms also need to be considered in concert with leprosy.
Yeah,
right?
That makes a lot of sense.
And then if we're trying to treat the leprosy, but the immunosuppression is maybe potentially making the population susceptible in the first place, keeping the disease hidden longer, and then setting the patients up for more disability development, then you've got to take out that vulnerability to help knock out the disease entirely, or at least bring it down to levels of countries that have development and sanitation. And so
that's very, very interesting. So partnerships through academic channels, through basically the research side of things that's required.
There's the research, but there's also things like, what are they using to actually change behavior? We had topics discussing how to change behavior, water and sanitation and hygiene, but what actually is effective? So they've tried programs working with schools. It's worked partially, but how can we look at it to make it better? So working in partnership, since we're talking about the same populations and some of the same things that are supporting all of our diseases are together. So therefore we need to work in partnership together, make these people healthier in their own environment, and then they can maybe fight these diseases off better themselves.
And what's the future role of an NGO such as yourselves from a data perspective?
So I very much appreciate that the Leprosy Mission has kept or maintained a research arm. Not every NGO that focuses on a disease keeps a research arm, and this is dealing with some of the very significant and extreme impoverished generations. So there are a lot of effective things that money could be spent on, but they've had the vision to say, we cannot stay with the way things are now, we have to make them better. And so research, we continually are trying to do. And as the Leprosy Mission, we take it and then we publish it. We put it in international journals, and I try very much to preferentially put it in journals that will be accessible to people that are in affected or endemic countries. So we work very hard to actually do what we can to get it for field implementation, or to the people who are in other areas of development such as diagnostics, to try and make differences for the people that we actually face every day.
Well, that's very, very admirable, and I suppose what I'm trying to get to is that the evidence that's being generated at NGO level in many, many resource poor settings could essentially be viewed as the backbone of a de facto sovereign state healthcare system. You know, people are not sat on, but they have a lot of data at hand, clinical data from patients that they've worked on in a specific disease setting. If you pool all of that together, if there was some kind of data brokerage or some kind of repository, would you strengthen or weaken the healthcare system in that region?
You could strengthen it. We're part of a consortium, for instance, of 8 different field sites that combines information on a certain type of leprosy reaction. So it's called the INLIST, or International Study Group for ENL. And that is putting hospitals and clinics together that deal with this particular type of leprosy reaction. None of us actually maybe have enough of this special type of reaction to run a clinical trial or perform a huge study on our own, but we just published a paper that had 300 or so patients among us that we were able to use a standardized assessment to see what was actually happening in the field, what are doctors actually doing, and how could we collect data from these patients to benefit other patients around the world.
Well, again, it's a very encouraging message that you're working towards an open source or open kind of framework in terms of the data generated and what you do with it. So I'd like to say thank you very, very much for making the very long journey from Nepal to London.
Thank you for having this meeting.
No, it's a pleasure as ours. Thank you very, very much. It was fascinating to hear you talk, and wish you all the very, very best with your work.
Thank you.